We're going to talk a little bit about a few different intervention cards today, starting first with Epi 1 to 1000. And it is important to mention the concentration for Epi because another common concentration is used in the medical field called Epi 1 to 10,000. And Epi 1 to 10,000 is traditionally referred to as cardiac Epi or intravenous Epi, whereas Epi 1 to 1,000, a far more concentrated version, is referred to as intramuscular Epi often, or perhaps anaphylactic, right? So maybe we could even put in here intramuscular, but perhaps that'll become apparent later. Now, the class and action, first of all, is just combined into one because sometimes it's difficult for me to describe the class without inadvertently describing the action. And you may already notice that this differs possibly from the card that you have. I recorded this video like a billionty times this morning, just kind of trying to think, how do I summarize for someone what a sympathomimetic is, what the sympathetic nervous system does, how receptor sites work in general, and then what agonism versus antagonism means, how you can't even really talk about beta 2 receptor sites without mentioning how bronchodilation occurs and how bronchioles have muscles, much like vasculature, which brings us into terms of vasoconstriction. And it's funny because just this one line becomes this enormous soup. And at the end of it, I just got to thinking, okay, what do I want from an EMT? If an EMT comes in and says, oh, I know that Epi 1 to 1000 is sympathomimetic, it's an agonist of alpha 1, beta 1, and beta 2 receptors, I would say, that's amazing. What does that mean? And if they were like, I don't know, I would think, oh, that sucks. But if they came in and said, I don't really know, I don't remember what you said the class of Epi is, but I know that it increases their blood pressure, it will increase their heart rate, and it causes bronchodilation, I'm much happier with that. And so I guess moving forward, I might be inclined to delete this, but I also think it's important to know. But what I think is even more important to know is what it actually does. So for now, I suppose I'm just going to mention both of them, and we'll leave this to the void or a later day of mystery. But this is really what I need you to know: that it increases blood pressure, heart rate, and causes bronchodilation. Bronchodilation means we're causing your bronchioles to dilate. We're causing your airways to relax. In a certain sense, it's like saying we're causing your lung space to expand. So maybe increasing blood pressure is obvious. Maybe increasing heart rate is obvious. What this part means, what the beta 2 agonism does, bronchodilation means, is that we're allowing more air to come in to your lungs. Now, the indication is, of course, why we should give a thing, and put simply, we would say anaphylaxis, which is its own entire lecture. More often than not, I think anaphylaxis is described as allergic reaction with 2 or more body systems. And I think that's a good description. My problem comes with the fact that somebody experiencing angioedema, right? Face swelling, tongue swelling, angioedema, fluid in the wrong place is, of course, what we mean by edema. You could argue that this, imagine what their trachea looks like potentially, or the area around their trachea. You might say, well, this is dermatological and respiratory, therefore 2 systems, but I don't know. I feel like that's complicated, too unnecessarily complicated. We'll look at somebody here with wheals or urticaria with a reaction dermatologically. And really, this is what I've just come to start describing anaphylaxis is: allergic reaction with more than a rash. That's what I mean to say. An allergic reaction with more than a rash. That's enough for me. If you see this in a patient, if you see angioedema, lips swelling, and you think, oh, it's just their lips swelling, give Epi. What if it's their airway? That's what I want you to do. If you come up and say, oh, their blood pressure is low, you might say, well, that's just one system. It's just their blood pressure system. Give epi. So I would like to describe anaphylaxis moving forward, I think, as an allergic reaction with more than a rash. They got just a rash, that's it. We'll let it ride without epi. I'm okay with that. The interesting part is that no one's getting in trouble for giving somebody with a urticaria epi. It may not be exactly what they need, but it's not a crazy thing. So indication. Why do we give it? Well, we're going to give epi 1 to 1,000 for any time we see an allergic reaction with more than a rash. Our doses for adult is going to be 0.3 milligrams. Q means every 10 minutes. Now, this isn't a hard and fast rule for me. I'm picturing a person transporting somebody in an ambulance who has angioedema saying, well, it's 9 minutes and 30 seconds. We better wait 30 more seconds here before we give our epi. Chances are I would probably be giving this every 5 minutes is my guess. If I wasn't a bit insecure about changing your drug cards after having printed them, I probably would just change this to every 5 minutes. But suffice it to say for now that it's usually a range, 5 to 15 minutes. I put 10 originally to split the difference after 2 years of watching students wait way too long to re-administer epi. I think I'm starting to become more aggressive with this. So you're not wrong. No, nobody's losing major points if they give this at 9 minutes. No one's losing points if they give it at 10 minutes. But I think on a long enough timeline, you'll see what I mean by how incredibly long watching somebody that really needs epi at 6 minutes can be. So I don't mean to be confusing here, but it's a range, really, and I try not to teach in ranges too much. Adult, 0.3 milligrams every 10 minutes is okay. It's also okay to give every 5 minutes. Now, we're calling this IM, of course, intramuscular. IM versus IV. Oh, here we go. Let's look at that. I am looking for a graphic. Maybe I just need to type it in. Just a picture of a butt, no big deal. Here is what I'm looking for. Intramuscular. Intravenous, as you can see, goes through the dermal tissue and into a vein, and that carries it directly past or directly into our system, primarily and largely going past our liver. So it's more concentrated, is I guess what I mean to say. Intramuscular does not go into the vein and therefore has to diffuse through the muscle and then go into the vasculature, and it can take longer, and then it's far less potent, far less concentrated in that way. And so here with the adult administration of epi, for an EMT we give 1 to 1,000 epi intramuscularly. And it's just as gnarly as it looks. 90 degrees against the tissue all the way to the hub. For pediatrics, we do need to dose it and wait. There's what we call the hand teddy method. We'll get into this a little bit later, but this is a great way of determining pediatric weights. We start on the thumb, 1-year-old, 3-year-old, 5-year-old, 7-year-old, 9-year-old. You said you have a 7-year-old? 1, 3, 5, 7. We go up by fives after 10. 10 kilograms, 15 kilograms, 20 kilograms, 25 kilograms. Average 7-year-old weighs 25 kilograms. Our epi says 0.01 milligrams. Now, I'm not strong at math, but thankfully as a very simple integer here, when it's 0.01, that means all we have to do is move the decimal point behind those two places. And so if I have, let's say, a 5-year-old with an allergic reaction more than a rash, 1-year-old, 3-year-old, 5-year-old, 10 kilograms, 15 kilograms, he weighs 20 kilograms. Our dose is 0.01, so that would mean we need to move the decimal over 2 places. That would be, oh, sorry, I'm going the wrong way. We would need to go not 2.0, but 0.2. So if that's not too confusing, if I have a 20 kilogram baby child, I need to move the decimal over, and I would give 0.2 milligrams per kilogram. Same rule applies here with the every 10. That is what I have on your card. I'm okay with every 5. And the max dose is adult dosing. I gotta be honest, the cheating way through this is merely just giving them half the dose. I don't think an EMT is going to be asked on the registry how much to give very specifically for a pediatric. And EpiPen juniors, in fact, are always dosed at Epi Junior is always going to be 0.5 milligrams. So I'm okay with you giving 0.5 milligrams, but you should know that it is weight-based to a max of an adult dose. The form is how it comes. Let's see if I can just give you Epi glass ampule, give you an example of this. Perfect. Here's what a glass ampule of epinephrine looks like. Well, limited by my bandwidth, it would seem. Right here. This is an ampule of epi. You'd wrap the top in gauze, pull it at a 90-degree angle, snap the top off, and then draw out the fluid. Now, one of the things that's important to note is that you would need a filtered needle to do that, because when you break this, little pieces of glass come in there, and there it was. That's super bad for veins. And so here is a standard needle. Maybe this is better. Here's a standard needle, just pulling up all the fluid and whatever glass falls into place. But a filtered needle traditionally looks like, this is a pretty low quality, I guess like this. It's a plastic tube, and it's got a little mesh here, super small particulate mesh, to prevent glass from coming through. And so that's what I mean by here when I say, hey, use a filtered straw when drawing out of glass ampules. Now, in many cases and in most departments, you are going to have an EpiPen to give to patients, but it should be known that you don't need one as a EMT, that you can literally break it out of an ampule, draw it up, and administer it yourself intramuscularly. If indication is the reason we should give something, contraindication is the reason that we shouldn't. This might seem a little counterintuitive here. How could somebody be allergic to the thing that fixes allergies? Well, traditionally, it's not that they're allergic to adrenaline or epi. Epi is what we call an endogenous chemical. Endogenous chemical. In fact, it's a hormone. What I mean by that is that our body makes it. But the epi we give people isn't pulled from someone. It's synthesized in a lab. And it is identical molecularly, but it's the microplastics that it's stored in, the container. Maybe it's the suspension that it's held in. It's not held in a suspension, but whatever it is, when somebody's allergic to epi, it's probably not the hormone that they're allergic to. It's in some way that it's delivered or carried is probably what it is. But either way, you'll meet one person, at least in your career, says they're allergic to it. We'll have a discussion about what to do with that at another time. Now, if contraindications is the reason we don't give something, the adverse effects is the stuff that happens when we give this medication that we don't want to happen, but is going to happen anyways. It's not always, but it is often. And I am constantly reminded of this when I'm working with a new partner, a new clinician, because I forget to mention, hey, epi makes them pop. And it definitely will. There's a lot of different receptor sites in your stomach that it will affect, and giving somebody epi will often make them throw up, and usually on the new guy because they forget to back away or simply don't know. If you think about your fight or flight system, the sympathetic nervous system, if a bear comes out of the woods and charges you, it's going to make you anxious, it's going to make you shake, and administering that hormone, that endogenous chemical, is going to make somebody anxious and tremulous. And so we should expect that as a normal reaction afterwards. Like I said, filtered straw is important when drawing out of glass ampules. That's to, of course, prevent the glass from getting into their veins. Sub-Q or subcutaneous is what SQ means. Do I still have it up here? Yeah. So subcutaneous essentially means going below the cutaneous tissue here, or into the cutaneous tissue, I guess I should say, for the fat. So I think the simplest way to describe this is that intramuscular bypasses cutaneous tissue, or subcutaneous tissue rather, and goes into the muscle, which is absorbed at a rapid rate, let's call it, and a subcutaneous administration can still work but is less rapid. And if we're giving somebody because they need to benefit from these adrenergic effects, from these sympathomimetic agonist effects, if somebody needs increased blood pressure, increased heart rates, and bronchodilation, I would rather you give it in the way that is most rapid, intramuscularly. The next thing that we want to talk about is oxygen administration. Now, of course, there's always oxygen in atmospheric gas, in normal air. So we're talking specifically about supplemental O2. FiO2 means the fraction of inspired oxygen. That just means that right now as we sit here, when I take in air, the FiO2, what is the FiO2 is asking me what portion of the air I just took in is oxygen specifically, and that's around 21%. Of course, the reason why oxygen benefits us is because it binds to our hemoglobin. Oxygen plus sugar equals energy. But it's also helping us exchange carbon dioxide to get the carbon dioxide out of our body. This can be an interesting and in-depth discussion. I try my best to make this as simple as possible. We're on the cusp of learning that EMTs before you had it much easier. It was almost never wrong to just give somebody a non-rebreather and put them on high-flow oxygen. It was the answer to every question. Your person has gray hair. Whoa, non-rebreather, 15 liters a minute. Good job, you're the best EMT. We're starting to learn that that's not the case. Now, it's not often a major problem. It's like me saying, hey, just drink a bunch of water today. It's good for you. And you'd say, but isn't too much water going to be harmful? And I'd say, yes, but only in extreme senses. And so I'm not trying to preach fear about administering oxygen for sure, but I don't think we're too long from just being very, very specific about how much oxygen we give, all things in moderation, right? And so to put it simply, dyspnea, meaning difficulty breathing. If your patient has difficulty breathing, you should put them on a nasal cannula at least. Now, if this is hyperventilation, somebody's just having a super hard time, they're freaking out, and so their body is making them breathe really fast, and they're like, I'm having trouble breathing. You know that that's not actually a lung problem, but maybe in the beginning of an assessment, you haven't figured that out yet. And so merely putting them on a nasal cannula at 1 or 2 liters is a great start while you solve the mystery. What it doesn't mean is that I walk in and see a 16-year-old boy who just got in an argument with his dad, who's breathing really fast, and I throw him on 15 liters of a non-rebreather. No, that's not what I'm saying. Even if he says difficulty breathing, I'm saying if somebody says difficulty breathing, and putting them on some oxygen is a good idea until you figure out what's going on. Now, my 15-year-old patient upset with his dad is a very different dynamic than a 72-year-old woman in the tripod position with accessory muscle use who's pink frothy sputum coming up. You put a nasal cannula on that person at 1, and I'm going to say, no, that's wrong. That person is obviously in respiratory distress. They need more. And so it takes a certain amount of thinking. It's not a one-size-fits-all situation here. So you might see this as odd to see both dyspnea and respiratory distress, but what I'm trying to kind of get across here is there are some people who are having trouble breathing that will benefit from some oxygen, and there are other people who are having substantial difficulty breathing and can just go immediately to a non-rebreather, and you're going to have to do your best to kind of ascertain where you want to start. Heart failure is perhaps a more complicated conversation. I've almost just tried to put this as shock, but this is largely just a distillation of what the American Heart Association says about when we should give oxygen. And we'll talk later about what heart failure looks like, but suffice it to say for now that if you see somebody with pale skin, if they have pink frothy sputum, if their heart is slowing down, if they're having profound difficulty, and you can't isolate it just to their respiratory distress, giving them oxygen is still a very good idea. So who do we give oxygen to? Who do we give supplemental oxygen to? Anyone with difficulty breathing, anyone that appears to be in respiratory distress, or anyone that despite these things, despite them saying, no, I don't think I'm having trouble breathing, and don't maybe even appear to be in respiratory distress, signs of heart failure can also be a strong indicator for giving oxygen. Our doses are simply a nasal cannula at 1 to 6 liters. Cannula, right? This goes across the face here, giving a small amount of oxygen into the nose. This is going to increase the amount of oxygen if they pull in 100 milliliters of air, and we put them on a cannula at 6. 44 of those milliliters of air are now oxygen. If we put them on a non-rebreather, it's going to increase it. This reservoir bag here is going to fill with oxygen, and now they're going to start taking breaths that are largely and directly coming from that bag, which is why we get almost 100% of the volume of air that they're breathing can become oxygen. Now, I'm intentionally saving this BVM for the last. In fact, I've often thought about having 2 oxygen cards, one that's passive and one that's active. Of course, a BVM is where we've gone from just passively letting the patient bring their own oxygen in to now forcefully administering positive pressure into their lungs. And it's my hope that you can see this almost as strange that I would put them on the same card, that they should be dramatically different experiences for our patients. Some people are struggling, but doing their own work. Their respirations are adequate. Their tidal volume is adequate. Their chest rise and fall is adequate. But if they are experiencing shallow respirations, or slow respirations, or irregular respirations, then we need to actually do the work for them, and that's where the BVM comes into play. Now, I have 15 to 25 liters per minute, and that's true, but I'm also okay with you just spinning the dial on the O2 tank and just letting it fly. It's a bit dramatic to say, but I just mean that, generally speaking, 25 is going to be the high end of a tank's capability. The form in which it comes in is perhaps obviously not a small glass ampule. It can come in just a whole myriad of different sizes. Oxygen tanks. Oh my goodness, right? And I don't expect you to know all of these, but I can guarantee you this will be helpful on the registry. And it's a good concept, I think, easy concept or simple at least to retain. A M tank is the one on your ambulance, and a D tank is the one on that you'll take to the doorstep. This M tank will be 4 foot tall. The D tank is the one that you'll see in Jamaica. No, it's the one that you'll see in your EMT bags, the ones that you'll see on your stretcher, the ones that you'll carry to the doorstep. T, for the record, T is the tallest tank. That's sometimes helpful. Now, there's no real contraindication for oxygen. I want to put a hypoxic drive. I want to put that. Maybe I should. But what I mean to say is that there's almost no case where I want you to think, wow, I really can't apply oxygen here. It's worth noting that the indication isn't simply an SpO2. It used to be this simple: for SpO2 of less than 95%. I don't say that anymore. We have to use our noggin. What I mean to say is I can walk up, see somebody that has a pulse ox of 91%, and the answer isn't to put them on oxygen because they were wearing nail polish, or they were in the cold air and they were experiencing vasoconstriction, and so it was diluting our understanding of what would be appropriate for oxygen administration. And by the same token, what I don't want you to say is, oh, I put them on a pulse ox and their pulse ox is 100%. So I don't need oxygen because the qualifier is less than 95. But it's 100% because they've been taking carbon monoxide and it's falsifying. that. So we just exclude the SpO2. I will admit that I think there's a bar. I think if you're less than 90%, I'm probably just going to put you on a cannula until I figure it out. And so I'm okay with you doing that too. But I really don't want you to be associating oxygen administration specifically or explicitly with SpO2 administration. Lastly, we're going to talk about our intervention card, which is shock management. Class action might be a little bit of a misnomer here, but just for holding parallel, that's why I've left it. Shock management is treatments and interventions aimed at reducing the workload on a body experiencing hypoperfusion. Oh my goodness, so many words. When I talk about shock, I'm not talking about psychogenic shock in most cases. I'm not talking about somebody seeing that the car that they wanted is half the cost and now they're just in shock. No, we're talking about people who don't have enough blood to circulate their body. We're talking about people whose hearts are failing. We're talking about people who may be having an adequate heart rate, adequate heart squeezing, and an adequate amount of blood, but their neck was broken and they can't control their vessels anymore. So all of their vessels dilate and it causes their blood pressure to plummet. So shock management is largely referring to hypovolemic low volume shock, meaning people that just don't have enough blood in them. That's largely who this is aimed at, but it's not exclusively who it's aimed at. Indications when we do a thing are signs of shock. Boy, is that a complicated description or discussion. But all I mean to say is these are people that we should look at that might have presentations that their body is not moving fluid like it should or doesn't possess as much fluid as it should. And so these might be pale patients. These might be patients whose heart rates are increasing to make up for blood loss. There's a whole myriad of different things. If I've got somebody who is experiencing changes in vital signs due to a traumatic event, trauma plus vital sign change is probably the simplest way to say it. That's going to cover 80% of the times you should do this. But all I mean to say is if I walk up and I think that you're in shock, we'll get into what shock means later largely, I want you to start doing this. Put oxygen on them as indicated. In many cases, this is just starting with a nasal cannula. If I walk up and a person's lost a limb and has perhaps lost a substantial amount of blood and is now losing consciousness, we're going to go ahead and move past the nasal cannula, go directly to the non-rebreather, right? Like I had said before, about 60% of a person's energy is devoted to keeping them warm. Putting a blanket on them can reduce that workload. And like I described previously, if we're looking at our trauma triad of death here, hypothermia, low body temperature, will lead us to coagulopathy, which will lead us to acidosis, which will then turn to more hypothermia, and around and around and around until we die even faster. So keeping people warm is very, very important. Laying them supine, right? Or on their back, perhaps, is a way of reducing workload on the heart as well. I almost shudder to say this because I don't really want you to remember this, but we used to teach Trendelenburg. We used to teach just put their legs up and that's going to allow blood to flow back to the heart. We don't do this anymore. This used to be the shock position. The shock position is not Trendelenburg anymore. We use supine position. We found that once we kicked the legs up, it was causing way too much work on the heart, and it's better to just lay them flat. So if you said, Mr. Fearon, my guy has some blood loss, what should I do? I would say, well, look, if he's got some blood loss, maybe put him on a nasal cannula, lay him supine if he can tolerate it, and cover him with a blanket if he can tolerate it. You say, well, my guy can't lay on his back. He says it makes difficulty breathing increase. It makes it harder to breathe. I say, okay, well then sit him up. That's fine. Is he still having trouble breathing? Then maybe we go from a nasal cannula to a non-rebreather. But ultimately, keeping him warm is very important, even if it's just putting a sheet on him to help conserve. Now for contraindications, again, there aren't largely contraindications for oxygen, but you do have to think it through. I don't want you to put a non-rebreather on somebody that's got a paper cut and is starting to look pale. Nasal cannula is fine. I most certainly don't want you to start ventilating that patient with a BVM. Position, the supine position could be dyspnea, like I said in my example here. If you lay your guy, look, if it's evidence-based, right? If you lay your guy back and he's like, no, I don't feel good, this feels way worse. Okay, well, sit him back up. It's not what he needed. But if he can tolerate it, you do want him supine. Fever would be a contraindication, perhaps for covering a guy with a blanket. It may not be a contraindication for putting a sheet over him. But it may be the case that if my guy has a fever of 102, let's say, and he's septic, maybe he got a surgery 2 days ago and now he's got a profound infection that's causing him to have a fever, and that infection is causing his blood pressure to go low, which would be a sign of shock. Perhaps the strongest sign of shock. Maybe it's something I should have said a millennia ago. The reason why I'm somewhat hesitant to mention hypotension is because hypotension is perhaps the last sign of shock. There are a million different signs for shock. One of the earliest, easiest signs would be altered mental status, specifically anxiety. One of the other most common early ones, is tachycardia and tachypnea, right? So increased heart rate, increased respiratory rate. I'm kind of trying to avoid these discussions just because they're long discussions. It doesn't mean everyone with tachycardia is in shock or everyone that's breathing fast is in shock. But if they're in shock, these are going to be their earliest signs, the first thing the body does, which means that if you say they're not probably in shock until they're hypotensive, I would say, no, they're doomed. That's one of the last things you'll see before they die. So anyways, if I've got a guy who has a fever, who can tolerate laying down, I'll probably want to put him on some oxygen. And I want to probably cover him with a sheet, maybe not a blanket, because I don't want to increase his fever or his body temperature. Lastly is the note that this is primarily for hypovolemic shock. It's not only for hypovolemic shock, but most of what you're going to be doing here, and most of the times this will be apparent, it'll be to low volume shock, being in shock because of a low blood volume. I'm going to end there. Don't want to get too long in the tooth. Please email me if you have any questions. We'll go into a lot of these far more in-depth concepts later and in different chapters. Have a great day.